Good afternoon, everyone. Thanks for joining us today for this Lunch and Learn series brought to you by the Office of Medical Student Research. The purpose of our office is to promote existing and upcoming research opportunities to all of our OSU medical students and to connect medical students with faculty research mentors. This Lunch and Learn series was created to highlight our faculty's research and to discuss opportunities for medical students to participate. Our office has a presence at both the OSU CHS Tulsa and Cherokee Nation campuses. So please visit us at our website to get more information about the office and ways in which we can, you can participate in our many research opportunities. And this series will be recorded and uploaded onto our YouTube channel, and you should be able to find the link on our website. And the videos are provided for those of you who may not be able to participate live, but be able to watch later. And for those of you who may want to revisit to gather information at a future date. Today, we have Dr. Kelly Murray, who is a clinical associate professor in the Department of Emergency Medicine, whose research involves emergency medicine, diabetes, academia, and clinical communication. And today, Dr. Murray will give us a presentation on research that she does, and we'll talk about opportunities for medical students who do research in emergency medicine and pharmacy. So please welcome Dr. Kelly Murray.
Thank you so much for the introduction, and to the Office of Medical Student Research for inviting me to come and chat. I thought a long time about what it was that I could contribute to helping medical students kind of bolster their CVs with research and maybe where they could fit into our department as well. And so what I want to do over the course of the next handful of minutes is give you a little bit of information, not only in what it is that my role is within my department, but also some of the research that I have dreamed up, some of the research that I've helped other people dream up, and then a few ideas of future projects and directions that I want to explore a little bit further. If at any point my feed goes out, I am going to blame it wholeheartedly on the OSU Medical Center's internet. And so please bear with me if that happens. Or send me a chat if something like that happens. And I think that I have enough screens up that I can monitor if that does happen. So let's jump right into it. So again, today we're going to talk about research in emergency medicine and pharmacy. The first thing I'll tell you is a little bit about how I stay organized. One of my roles within the Department of Emergency Medicine is to direct the resident research endeavors that happen with the EM group. And so I'm kind of the point person for all of the emergency medicine residents that come through our program on their quality improvement projects, as well as their research projects, and can help them get connected with different people that can help them move their projects forward. A few research areas that I am involved in include discharge prescription errors within the emergency department. Of course, I mentioned the emergency medicine resident. We have a few really exciting quality improvement programs that are going on right now. I am helpful with our pharmacy residents as well, and I'll tell you about a couple projects that I'm really excited about that are still in the works. I was able to be a part of some industry-sponsored COVID-19 research over the past year. And so I'll give you a little bit more information about those 3 studies that I was able to be a sub-investigator and then a co-PI on for our state. And then we'll talk about a few last projects, including resident wellness and education that really tie back to buzzword burnout and things like that, which may help us to keep residents from moving into that place where they are no longer able to move forward and just need some more help. So we will then talk about some future projects and some places where I'd like to dream up some fun ideas and may need some med students to help me out. So I mentioned I'd tell you a little bit about how I stayed organized. These are a handful of the active projects and QI endeavors that we have going on within my department. So this PowerPoint slide in the forefront of my mind whenever I'm thinking about what it is that I need to do, where I need to focus, how I can move something from the analysis, writing, and editing columns into the awaiting review after we've submitted it for publication. So as you can tell, I have a few that have stacked up there, and I'm needing to move those beyond that submission phase. So we'll talk about a few of these projects specifically. But again, this is some of these ideas are mine. Some of these ideas are others that I am just very lucky to be a part of. So I'm going to start with a few projects that I've done in regard to prescription errors. So when it comes to being a part of the Department of Emergency Medicine, things are moving very quickly downstairs. And when it comes to errors, we always think about, errors at the bedside and trying to prevent those as best as we can. But what happens to the discharge prescription errors that go unnoticed, that do get sent out of our department, and what happens from there? So what I've started doing is trying to describe and quantify the prescription errors that exist in our discharge prescriptions. A little bit of history about me. I started, so I graduated from pharmacy school in 2007 from the OU College of Pharmacy here in Tulsa, and I did a residency, and then I took a faculty position with OU for about 7 years before I moved over here in 2013. I officially took a faculty position in 2015 with OSU, and I've been here ever since. But whenever I moved into the emergency department, I tried to meld these two worlds of mine together where, I'm now having to be a part of this acute care place, but we also have this interest and love of ambulatory care, or essentially family medicine type chronic disease state management, where I came from in my former pharmacy life before I got to the ED. And so when it comes to prescription errors, those prescriptions that move from the inpatient world or the ED or urgent care, or wherever it may be, to the to the retail pharmacy or the community pharmacy setting, we would catch a ton of errors and then, try to get those errors taken care of. And it was quite an issue. And so from a grassroots perspective, I wanted to try to do the best that I could at preventing any type of discharge prescription from being sent home with a patient that had an error within it. And so I wanted to really get to know what those errors looked like. So you'll see these two projects that I had some pharmacy and medicine resident help with over the last handful of years. The first one was really just to describe what those errors looked like. So I took a convenient sample of 1,000 discharge prescriptions from February 2015 and wanted to determine what the overall prescription error rate was. When it comes to how to define an error, this is a little bit different, and it's going to vary from person to person. But what we found was the majority of the errors that we found were incomplete or inadequate prescriptions, meaning they had missing directions or a notation that said take as directed instead of how exactly the physician or prescriber wanted that prescription to be taken. And overall, we found that error rate to be about 13.5%, which is pretty consistent to all of the other prescription error rates that have been found in the medical literature. Excuse me. Sorry. Other things to quantify as far as the discharge prescription errors are how many were adult errors versus pediatric prescription errors. And you can see here that we found about double the amount of pediatric prescription errors than we did adults, and that 22.7% of all of the pediatric prescriptions that were sent out had errors within them. Among all of the errors that we found, antibiotics as a class had the most errors as well, and about 15% of those scripts having some type of error within them. As far as who wrote the prescriptions and where we could potentially target education, we found that our emergency medicine residents wrote prescriptions with fewer errors than our off-service residents. And this likely or potentially had something to do with the difference in what type of prescriptions our off-service residents were writing. They may not have been used to writing prescriptions out of the emergency department compared to prescriptions out of their services or being discharged from the hospital. And then lastly, I wanted to find out when these errors were happening. And this ties directly back to when could a pharmacist potentially be helpful in an emergency department? And as you would imagine, about the time that an ER gets busy is about when those errors are going to start to occur. So anywhere from 10 a.m. to about 6 p.m. is where we found about 77% of our errors. So out of the 135 prescription errors that we found, or 77% were between that shift time. So that was one place where over the course of the years, as I've adapted my emergency medicine service, I try to be in the ED during that time period or have someone in the ED during that time period so that they can answer questions about discharge prescriptions if they do come up. So, and just to quantify or to characterize that, here is the graph that looks at the prescription errors by hour. And as you can see, that time period between 10 a.m. and 6 p.m. is really where we saw that peak happen. And it's usually about the point where the ED starts getting really busy. So around noon to 2 p.m. So let's move into the second discharge prescription error study that I dreamed up. As we found with the antibiotic prescriptions having quite a bit of errors and being the highest within class error rate of 15%, I wanted to look at that a little bit further. And so I had a resident and a pharmacy student look at a random sample of 1,000 prescriptions from a single academic year. So what we did as far as methodology is concerned is I wanted to look at scripts from all across a resident cycle as opposed to a single month like I did in the previous study. So within that single month, that is going to limit the number of prescribers that are in the emergency department, whereas with this academic year sample draw, I'm able to get a little bit more of a random sample looking at each month, not just the busy month or the month where we have a lot of flu patients. And so therefore we have a ton more patients in the emergency department during the month of February. This is going to be just a little bit more consistent. I think might be a little bit more representative of what actually happens. And then when it comes to how we reviewed those prescriptions for errors, again, we had a pharmacy resident, a medical resident, an emergency medicine attending physician, and then myself, an emergency medicine pharmacy member. We looked at a sample of 250 prescriptions each, and then we each reviewed someone else's sample of 250 prescriptions to make sure that everything agreed. If we had any disagreements, then that person who reviewed it was the tiebreaker. So what we found with these discharge antibiotic prescriptions was our total antibiotic error rate was 22.2%, with pediatric prescription error rates being higher at 33%. The most common dosing error was dosing outside of the recommended range, which was actually a subtherapeutic range where we saw not enough antibiotic to be prescribed or not enough days of that antibiotic being prescribed. And so essentially a subtherapeutic dose can then lead us down the path of antimicrobial resistance because that bacteria can then recognize that antibiotic and overcome its bactericidal or bacteriostatic capabilities, and then could lend itself down the path of an antibiotic no longer working for that patient. And so we want to avoid any subtherapeutic dosing as best as we can. The most common antibiotics within that class that had errors include nitrofurantoin, which we use for cystitis that's uncomplicated. We saw a lot of amoxicillin antibiotic prescription errors as well as levofloxacin. Same as far as the timing is concerned as well. So I wanted to see if that matched what we saw in our first study. And essentially we saw the majority of our errors between 11 a.m. and 6 p.m. again. So something that was pretty consistent in terms of when we really, really need to be watching those discharge prescriptions. So with regard to discharge scripts, this is something that I want to continue to work on. I think that this is a place where we can really make a big difference in the emergency department, making sure that our patients are getting sent out on scripts that are correct and have no errors. Unfortunately, I am only one in my department. We don't have any other emergency medicine pharmacists that work with us in the hospital. And so I am pulled a little bit thin, but this is something that if I could have folks that want to help tailor educational interventions as far as how best to prescribe antibiotics, this is something to work through. Also, we have since moved to Epic from Meditech. So the Meditech prescription error rate may be different than now that we have Epic, our error rate may be different at this point. And so that's something that I would want to see if it matched because EPIC just gives you just a little bit more information as far as what types of options exist, as far as what could you prescribe, what should you prescribe, is this outside of the dosing range, just gives you a few more error flags that you then have to address to make sure that that's what you want to do. And so it might potentially catch a few of these discharge antibiotic prescription errors that we saw the last time. So now I'm going to jump into a few of our emergency medicine resident quality improvement projects that I've been fortunate enough to get to help see through. Most of these are still in progress. So these haven't resulted in posters or publications at this point, but we anticipate moving a lot of these projects forward into that realm to showcase what it is that our residents are doing and how they're impacting patient care. So the first one is one that I'm very excited about. We will commonly, I say commonly, that's not exactly correct. In the emergency department, we have patients that are in need of pressure support. So if they are getting ready to be intubated, if they are close to arresting, sometimes we need to give them a bit of a pressor, a vasopressor, to keep their blood pressure up or their heart rate up, or maybe both. This is a little bit more commonly done in the operating room with anesthesia. This is something that they've been doing for years and years now, but it's a lot less common in the emergency department. In the ED, things are a lot more quick, and things are just a little bit more critical whenever a patient's blood pressure and pulse start to drop. There are very few things that you can do, and things have to happen in a very quick fashion in order to get that pressure support that you're looking for. So with that, there are not a lot of options when it comes to push dose pressors. So when I say pressors, I mean epinephrine and phenylephrine. Phenylephrine has predominantly alpha effects, and so you're not going to see its effect on the heart rate. You're really just going to see its effect with the blood pressure, which is sometimes what we want, especially if we have a patient who is tachycardic and we are trying to prevent that arrhythmia as opposed to cause it. So when it comes to phenylephrine, we have an option that is pre-made. Phenylephrine comes in a 10 ml syringe that is 100 micrograms per mil. And you can push that in 0.5 to 2 milliliters every 2 to 5 minutes in order to keep that. This is the one that they use most commonly in anesthesia. But more commonly, you're going to see our emergency medicine docs reach for epinephrine, whether it is mixing up an epinephrine drip at the bedside or trying to mix epinephrine into a push dose format as well. And so the way that this has to be done, it does not exist in a pre-made manufacturer formulation. You have to do it at the bedside. And you will take 1 milliliter of the crash cart epinephrine, which is 10 mils, and you will mix it into 9 milliliters of normal saline. And so oftentimes there is an error when it comes to mixing. And then there's also an error when it comes to dosing. So sometimes that is all pushed all at once instead of in 5 to 20 microgram equivalents. And when it comes to this, pharmacy really tends to shy away from allowing physicians and nurses at the bedside just because of how common it is for dosing errors and mixing errors to occur. So what we wanted to do is, in the instance that an emergency medicine physician needs to use a push dose pressor at the bedside, we wanted to do a quality improvement measure where we were testing them on what their knowledge is before an educational endeavor, and then testing them after that educational endeavor. So we did this actually about a week and a half ago, which was a lot of fun. Our medicine residents that really took this and ran with it did a wonderful job leading the cases, building those educational PowerPoints, making the pre and post test. And then we have already seen some interesting information as far as how the post test improved. Granted, our sample size is really small, and so you have to take that for what it's worth. But it is this opportunity for us to get to showcase what education can do, especially whenever you give it in didactic format, as well as put it into practice in a simulation center like we got to do over at the Tandy building. So a really cool project we've gotten to do. We will be following up with another post test to check retention of knowledge of mixing and dosing push dose pressors in 3 months before our seniors leave us. So we're excited to see where this goes. We anticipate that this is going to be one of those sim labs that we get to do year in and year out, just to make sure that our residents do stay fresh on this knowledge and that we educate our incoming interns as well. A few other quality improvement projects that we have going. We've recently, so whenever we were still in Meditech, we wanted to optimize our massive transfusion protocol. That was one thing that a few of our residents really took and ran with. We also got to have a few of our residents pair up with internal medicine, where we looked at the airway boxes. So let's say you have a patient in the hospital and they are not in the ICU and they're not in the emergency department, but they need to be intubated in an emergent fashion. Whenever the residents would grab the airway boxes in order to do that, the airway boxes were not standardized. And so sometimes they would have a MAC blade, sometimes they would not, sometimes they would have a Miller, sometimes they wouldn't. All of these different things were causing problems, and it allowed the residents, it caused the residents to not be as successful in their first pass attempt at getting a patient intubated, which then can lead down the pathway of being more complicated and having more complications down the road. And so the quality improvement project that existed was we needed to find a way to standardize the airway boxes within our hospital. So these two residents took these airway boxes, they essentially made a checklist. They put this in charge of one department is now in charge of the airway boxes. And we are now moving into a new project where we are going to set up a randomized controlled trial looking at standard intubation on the floor versus an iGel intubation on the floor, which is what you'll see IMSA using. So in the ICU, in the emergency department, where we control intubations just a little bit differently, those first pass successes tend to be a bit higher than if you're on the floor, if you're in a unit where things get a little bit more chaotic. So if we are to set up this study to look at the first pass success rate of placing an iGel, which essentially just fills the airway and allows you to pass a tube a little bit easier versus a standard intubation, if we have more success at first pass in that sense. And so really excited about where this project is going. Again, we have a meeting coming up in about a week and a half to get that RCT designed and submitted to IRB. So very excited there. Another quality improvement project, which was close to my heart, this was back in the Meditech days. So again, it's a little bit less needed now, but we had a couple of our residents design a pediatric medication order set. So because we see so many errors in our pediatric prescriptions, not only in the discharge prescription side, but also in the one-time dose in the emergency department side, we wanted to set up a medication order set that was evidence-based and allowed you to pull in the patient's weight in order to make the determination on what medication dose to give to that pediatric patient. So again, allowed for fewer medication errors and dosing errors to happen, which is kind of nice. A few other resident projects are more on the research side, where we've had some interesting patients come in. So we have a few case reports that they are working on. The first one is a phosphorus trifluoride gas exposure. So this was a workplace exposure where a gentleman came in and looked essentially like a carbon monoxide poisoning. There are no case reports out there on phosphorus trifluoride gas exposure. And so we wanted to get the information out about how we treated him. And we are currently in the second submission process for that case report. So that one is hopefully well on its way to getting published eventually. We also have another case report where we had a patient who had confused her, oh gosh, I'm losing my word. She thought that she was drinking magnesium citrate that was Equate brand from Walmart. And instead she took a big gulp of a humidifier liquid, which had camphor in it. That camphor is, that smell that you immediately recognize that you can think of like a Vicks vapor rub. If that gets ingested, it can cause seizures and be very toxic to the patient. And so patient took a big swig of this bottle of humidifier solution, thinking it was magnesium citrate. And so presented to the emergency department. We're writing that up just because of the interesting how the bottles looked so very similar to what she thought she was drinking versus what she actually did. And then what happened with her course over the time that she was here with us. We also who recently injected kratom, which is a drug of abuse. The patient had been out of their buprenorphine for opioid use disorder and instead used kratom. This isn't typically injected, and it ended up causing compartment syndrome for this gentleman and a fasciotomy. So we're going to write that up as well, and our residents are working on that as we speak. So next are a couple projects I want to tell you about as far as my pharmacy resident research is concerned. So the first project that we'll talk about is one that is very close to my heart. I have quite the interest in diabetes. Again, from my outpatient pharmacy days, I was helping patients manage their diabetes regimens. And I had a few patients where DKA was a concern with them because of non-compliance and things like that. So when a patient isn't compliant with their insulin, they can move into diabetic ketoacidosis, which then can be life-threatening. And so the way to get them out of DKA, halt that ketosis, and give them insulin essentially so their cell can uptake the glucose that's required in order to provide them the energy that they need. Whenever you're looking at how to dose insulin, when I started at OSU, all I knew essentially about how to treat DKA is what I had learned in school and what the guidelines said. And so I'd brushed up on the guidelines and I had figured out that, okay, we are either going to be using a bolus with an infusion regimen of 0.1 units per kilo as a bolus, and then 0.1 units per kilo per hour as a drip rate, or we're going to just go straight to the drip rate and do the 0.14 units per kilo per hour drip rate. Whenever I got to OSU, I realized that is nowhere near what our doctors actually do, and I could not figure out why it is. So when you look at the guidelines and you start to dissect why it is some of the guidelines say what they do, you really want to dig into the literature behind those recommendations. And so I found those bolus and infusion regimens, as well as just the plain infusion regimens. And turns out this study by Katabshi, who then went on to influence the writing of the hyperglycemia standards of care, which are still what we use today for DKA and hyperglycemic hyperosmolar state. That paper was with 37 patients divided into 3 different groups. And so we're essentially making these practice decisions based on teeny tiny numbers of patients. And ultimately our doctors were like, really what we want to do is we just want to start that ketosis, or we want to halt that ketosis by starting the insulin drip. We only have a certain number of nurses down in the emergency department, whereas whenever the patient gets up to the ICU, they have 1-to-1 nursing care. We don't have that. We have 3-to-1 nursing care. And so to ask our nurse in the emergency department to so tightly control their insulin drip and their glucose rates and how quickly it's falling is just asking a little bit too much, especially when there are other critical patients in the department. So what I wanted to know was, does this actually make a difference? If we were to give a patient a weight-based starting dose of an insulin drip and compared it to the patients that we already know are not getting weight-based regimens. Instead, they're just getting a non-weight-based regimen, which is like a fixed dose of 3 units per kilo per hour, or something like that. Does that make a difference in their time to resolution of ketoacidosis? Because ultimately, that's what we want to see, right? We want to see their acidosis resolve. We want to see them get transitioned to sub-Q insulin. We want to see them not have hypoglycemic events. And we want to get them out of the hospital back on their regimens. So that's what we ultimately set out to do. So I gave this idea to my pharmacy resident and one of my emergency medicine third years, and they have run with it. And it's been really exciting to watch this come out. So not to steal any of their thunder, because this is going to be presented at our quality improvement symposium coming up in a few months, I believe it is. So go make sure you take a walk by and check out their paper, their poster. We hope to be able to get this presented at other conferences and potentially published as well. So what we've seen so far, and again, this doesn't include the statistical analysis that's been run, but the time to resolution of DKA was shorter actually in our non-weight-based group, meaning that guideline weight-based group had a longer time to resolution of DKA versus our non-weight-based group of about 6 to 7 hours. And so kind of an interesting finding there. Whether that's statistically significant, we will find out. Also, we found there were more hypoglycemic events in the weight-based group, which this is, again, kind of predictable because we are giving them more insulin as opposed to that lower fixed dose rate in 2 to 29 or 2 versus 29 events in those. The one thing that I do want to flesh out just a little bit more is we did see more deaths in the non-weight-based group in 3 versus 1 in the weight-based group. And so I want to look into those patient charts a little bit more before we comment on what happened there. The next resident project that I'm excited to tell you about is in direct relation to metabolic syndrome monitoring in patients that are on second-generation antipsychotics, as well as highly active antiretroviral therapy for HIV. So one of my residents was very highly interested in HIV as well as psychiatry. And so I paired her with our HIV pharmacist and stayed on board as the resident psychiatry, psychopharmacotherapy expert, I suppose. And we designed this project where we looked at the monitoring parameters for patients who are on second generation antipsychotic therapies, which have a higher incidence of metabolic syndrome, and looked at those patients who are also on antiretrovirals that may put them at risk for the same type of metabolic syndrome type side effects. So when you're looking at monitoring for metabolic syndrome on patients who are on SGAs, I've clipped this table here for you to show how often you're supposed to be monitoring for weight, how often you need to be monitoring for glucose and for lipids and blood pressure and things like that. And what we wanted to do is look to see if these guidelines were being followed in our antiretroviral patient population who are also receiving an antipsychotic. So we wanted to look at that prevalence of metabolic syndrome and then look to risk management practices for patients who are on both of these classes of drugs. Ultimately, we found 58 patients that met criteria of being on both of these classes of medications concomitantly for 6 months or longer. And 20% of those 20 of those 58 patients met criteria. None of them had an ICD-10 code stating that they had metabolic syndrome. 0 of them were also monitored using this recommended monitoring protocol from the ADA and American Psychiatric Association. So a great area for improvement as far as what we can do in order to optimize and minimize our harm that we cause to our patients who are on both antiretrovirals who require second generation antipsychotics. So now a very brief blurb about resident education and wellness. Again, I know that burnout is a big topic of discussion, and how do we prevent this, and how do we potentially get a resident into a program that then will support them in the ways that they need to be supportive, potentially based on personality tests, or how can they support themselves by learning a little bit more about intrinsically what's happening in their body whenever they have stress. And so I have these 2 different teams that are working on a couple different projects. The first one is a couple residents in both our internal medicine and our emergency medicine programs, as well as one of our internal medicine faculty members who are working on describing the Enneagram and medical education as it relates to resident education and wellness. We have Dr. Vassar in on this project, and we're grateful for his support. We see this project, we're essentially doing a literature review right now where we're describing how the Enneagram may be applicable to a medical resident and where this could possibly affect them in terms of what type of program they might fit best in and what type of attending they might work well with, different things like that. Or do we put them out of their comfort zone by mismatching them with the different personality type and see if that then pushes them beyond where they felt that they were capable of going. So that's one project. Again, we see this being applicable in terms of not only resident education, but possibly even medical student education. And those ideas are still kind of being dreamed up right now. The other project, which includes resident wellness, is through the, I'm not sure if any of you all have heard of the wearable technologies, kind of like Fitbit, but it's called Whoop, and it tracks, it can track sleep, it can track how well you recover, whether your sleep is impacting your recovery. It also tracks your heart rate variability, which is essentially how your body handles stress and adapts to stress. And so in our residents who are in more stressful situations, how does their body then recover after that happens? Also, does this, by wearing this technology, does this give them more light into how their body adapts if they go home and have a drink at the end of a stressful shift? Like, what does that do to their recovery? Does it decrease their alcohol use? Does it increase their exercise? And different things like that. And so again, we're just in the literature review phase of this. This will eventually, hopefully, turn into a grant that we're then able to test this in a more prospective fashion in our emergency medicine, internal medicine groups. So brief blip on COVID-19 research. So I feel very fortunate that I was asked to be a part of COVID research within OSU Medical Center. There were 3 studies that we attempted to be involved in, and only one of them had actually ended up enrolling patients. And I will walk you through each of these. The first is the Novartis-sponsored hydroxychloroquine study. This was where we looked at hydroxychloroquine with or without azithromycin. This was at the very beginning of COVID. And so it was after that very first paper came out from France, from Gautret and colleagues, that showed that viral clearance was much better whenever you use the combination of hydroxychloroquine and azithromycin. So that eventually stopped before we were even able to enroll patients for obvious reasons. We also then were invited to participate in the BLAZE-2 study, which is an Eli Lilly and National Institutes of Allergy and Infectious Diseases study. This is part of the CoVPN group, which is COVID Prevention Network. The CoVPN group does a lot with vaccine research as well, and so that might sound familiar. And then the BLAZE-2 study specifically is on monoclonal antibodies, the bamlanivimab and edecevinib. And then the last study that we were a part of was the Cove Barrier study. This is an Eli Lilly sponsored study as well, looking at baricitinib in hospitalized patients requiring supplemental oxygen. So I wanted to walk you through the timeline of what that looked like, just in terms of where things happened in COVID and how OSU was involved in this. So in April, the hydroxychloroquine study was posted by the drug manufacturing company. We decided that this was a study we wanted to be a part of. They anticipated that we were going to need about 444 patients within this study in order to power it appropriately. So we joined the study. We never enrolled anyone. The enrollment criteria was very strict. And the Novartis study, the Novartis group essentially terminated the study. This was about the point in time where we were starting to see more literature come out about how hydroxychloroquine really didn't amount to what we hoped that it did. And Novartis was seeing that although there weren't any issues with safety in the 2020 patients that they were able to get enrolled before they terminated it, they were seeing that the other studies weren't showing any benefit as well, and they were going to need a bigger power in order to see a difference. And so they decided to stop that study. So about that point, we decided that we needed to start looking for other studies. And so we thought that the Cove Barrier study was one that we wanted to participate in. And this is, again, the study that was sponsored by Lilly, looking at baricitinib and how baricitinib affects the patient who is hospitalized with COVID, who requires joined this study right after we terminated with the Novartis group in July, and we enrolled our first patient less than a month later within our hospital. We enrolled 20 patients here at OSU, and that 20th patient was enrolled in December. About a week or two later of that last patient being enrolled here at our hospital, the ACTT2 results were released, which showed really a good benefit with baricitinib in combination with remdesivir. And so this is what ultimately got baricitinib approved for emergency use authorization. Once about a couple weeks later from the ACTT2 results were released, the Cove Barrier trial that we were a part of met their enrollment goal of 1,400 patients. We're still awaiting the results of that trial, but that is something that we are no longer enrolling patients in our hospital. So kind of interesting there. So then the last one I'm going to add to the mix is the BLAZE-2 antibody study. Dr. Salman and myself were named the Oklahoma State Primary Investigators meeting. This study required each state within the United States to have a primary investigator on the study that would then advise nursing homes whether or not that patient qualified for monoclonal antibody infusion if an index patient case of COVID was identified within that nursing home. So kind of an interesting study. Again, we have not seen the results of this study yet. This study was very much in a flux about the point of bamlanivimab being approved for EUA. That was about the point that Eli Lilly and the NIAID decided that they wanted to instead study at bamlanivimab plus the edazevenib. I am not going to be able to say that. I need to practice that so many times. So we never ended up enrolling any nursing homes within the study in the state of Oklahoma. But this one, again, ate up a ton of time. It was very complicated and very interesting to be a part of. BLAZE-2's enrollment was closed about 3 or 4 weeks ago. And so they're no longer enrolling within the study, and we're waiting results of that trial as well. So a few places where I see med students being able to help the projects that I have underway, the ideas that I've dreamed up, places where I'd love to be able to, have somebody on the team that can help me with a few of the things that I don't have a ton of time to really dig into. I am very interested in minimizing prescription errors, whether that is from a discharge prescription perspective or a medication administration perspective at the bedside. I think this is something where we can really make a difference. And there are so many errors that happen that are preventable. So many hospital admissions and emergency department visits that happen because of prescription errors. I think this is a place where we can really make a difference. I also want to see dosing optimized in the emergency department. So are we prescribing drugs at the proper dose for the proper regimen, for the proper duration of time? Medication reconciliation. So when a patient moves from one place in the hospital to the next, or when they move from the emergency department to discharge, there are so many errors that may exist on their medication list that are confusing, and they may not know what to do with those medications. Do I need to keep taking this? Do I need to stop it? What should I do? So some places where we can most definitely intervene there. I have a personal interest in the weight effects of medications. I think there are a lot of antidepressants that are going untapped as far as, maybe we need to be monitoring mirtazapine the same way we're monitoring second generation antipsychotics. And then from my previous days back in OU, I have an interest in migraine as well. This is an area where I'd done some previous research in the community pharmacy setting, and I think that I can move that into the emergency department as well. So how can students help? I always need help with literature review. Writing is something that it just doesn't come as naturally to me as it does to some of our medical students. And so I would love to have somebody help me out in some of these background sections and discussion sections where we do need that really good medical writing. I would love to have some help with data collection. So when it really comes down to it, crunching numbers, putting things in spreadsheets, and then seeing those through to data analysis. Lastly, I have a handful of manuscripts that I'd love to see published. If I could get some students involved in that, that would be great. And then lastly, what's the fun in doing these research projects if you don't get to spread the word of all of the fun things that you got to do? So presenting them at not only our OSU research days, our quality symposiums, but also at more national conferences and statewide conferences as well. So with that, I will wrap it up. I've left a handful of minutes, hopefully, for some questions if anyone has any. I'll stop sharing as well.
Hey, Dr. Murray.
Hey, how's it going?
Pretty good. Thanks for the presentation. Just had a couple of questions. So in regards to maybe helping you out with the writing portion or the literature review portion, if I'm interested in something like that, would I just kind of reach out to your email personally?
Please do. Absolutely. And I can pair you with a we can look at what your interests are and where you may see yourself fitting best. And then we can work through what that would look like as far as what we needed for that project specifically. If you have other ideas of things that you'd like to write up as well, I'd be happy to mentor you on that too.
Okay, awesome. Thank you.
Yeah, absolutely. Thank you. What other questions can I answer?
Hi, this is Ashton. I'm on the research committee for the Student Government Association. Do you mind if I share on our class page the types of projects you're working on and what you're looking for students to do, along with your email, so they can reach out as well?
I would love it if you did. Thank you so much.
Well, thank you.
Okay, any more questions from anyone? Once, going twice. All righty. Well, I really appreciate you, Dr. Murray. That was really great information and really great discussion. Really had me interested, and now I know when not to ask for my prescriptions and and then.
It's all about the healthcare team, right? I mean, we all have our own roles and our functions, and the identification of the errors is the first piece. It's how do we move forward and how do we keep those errors from impacting the patient in general. And so, I think that we have a lot of avenues where we can make some difference as a part of a team, not just, pointing out the bad stuff and then not doing anything about it. So hopefully that's helpful.
And one of the questions I did have, as we're getting into the end of our, spring semester, it's usually our big time of our own stress as students and stuff. What are some preliminary thoughts that you'd have, would be advice for students on things like that?
Advice as far as what's concerned? I'm sorry.
With your study on stress within residency, what are some advice that you would have for overall for students and even faculty like us?
Yeah, and it's a really good question. So I think, again, I feel like this is a little bit more anecdotal than it is research-based at this point. So please take that for what it is. But I think, you have to have your outlets and you have to have the things that are going to help decrease your stress. The mandatory wellness events and those types of things, I don't know if they necessarily pan out as far as really making a difference. But if you yourself know that when you exercise, your stress level goes down and your body recovers a little bit easier, or if you don't drink alcohol that night, you're going to feel better the next day. I mean, I think that if you're just in tune with what your body needs, I think that that's a super helpful thing to have. Again, I'm a proponent. I will be very biased towards the wearable technology. I think it's taught me a lot about myself, and it's allowed me the opportunity to know where I can work on myself. My sleep is actually really great, but when I exercise, I feel a lot better. And so it's kind of that reminder for me that I just need to make sure that I do those types of things. As you are nearing this stressful point in the semester, you've got a month and a half or so until classes are up. Just make sure that you are factoring in that time in your schedule to do those things that decrease your level of burnout. So that way, whenever you do come back to your studies and come back to your work, that you're able to give it the best that you can. Hope that's helpful.
Sounds excellent. Well, is there any more questions or anyone else have anything else to ask? Dr. Murray, do you have anything more you'd like to add?
I don't. I'm just grateful for those of you that joined and those that'll be watching online. If you have any questions, please don't hesitate to reach out and email. My email is Kelly, KELLY.Murray, MURRAY @okstate.edu.
Okay, well, thank you very much. And don't forget, our next Lunch and Learn will be April 21 on the 2021 at 1 p.m. with Dr. Colony Fugate, who is a clinical professor of pediatrics. So I appreciate you. I appreciate all of you guys for popping in, and I thank all of you for joining. And have a good rest of the day. Thank you.